it's really interesting to try and disentangle the role of GLP-1 in the kidney. And we now know that there are GLP-1 receptors in the kidney, often in the immune cells. And of course, in flow, we also saw a significant reduction in CRP by about 40%. So these drugs appear to have an important anti-inflammatory effects that may be specific and not necessarily related, for example, to their effects on weight loss, which might also be expected to reduce inflammation. So inflammation appears to be an important part of the story. The remodel trial, which was presented at the American Society of Nephrology meeting last year, can help us, I think, to further disentangle that. And I think there's a lot more work we need to do to fully understand that. But it tells us that there are an array of different effects that are complicated, but are likely to be specific and separate from the weight-related effects. Now, the cardiovascular benefits, the mortality effects, these drugs do so many things, almost all of which are beneficial. We're now seeing reports of reductions in the risk of osteoarthritis and joint problems in people treated with these agents. So the benefits are likely to extend more broadly, and some of these interrelate. If someone has less joint pain, they're more likely to be physically active, and that might help them with their general health as well as with their body weight. But in terms of the nature of the specific benefits and which of those is most important for progression of kidney disease, I think that's a little bit more difficult to tell. It may become easier over time as we start to learn about, for example, the effects of anti-inflammatory therapy using other agents. There are trials of IL-6 receptor antagonists out there at the moment that are profoundly anti-inflammatory and will help us understand whether anti-inflammatory therapy per se helps protect kidney function. And that may help us understand what the role of CRP reduction in flow was, for example, in terms of the kidney protective effects. But at the moment, I think what we know is that it's likely to be multifactorial, it's complicated, and we really need to do more work to understand it better. The obvious next question is, well, does the drug also work in people without diabetes? And that's a question that hasn't been properly assessed yet. There are some strong clues from, for example, the SELECT trial, which was a trial, again, of semaglutide, but this time in non-diabetic obese people targeting weight loss, where improvement in a range of kidney parameters was also seen that appeared entirely consistent with what we saw, for example, in the FLOW trial. There were reductions in albuminuria, there were slower loss of kidney function, etc. But that trial wasn't designed to properly test whether the same sort of kidney protective effects exist. So I think that's a really important question and a really exciting opportunity. With SGLT2 inhibitors, we saw that their kidney benefits were just as impressive in people with kidney disease who didn't have diabetes as those who did, suggesting a non-glucose-related mechanism of action. I suspect we'll see the same with GLP-1 receptor agonists. And I suspect and hope that in the future, trials will show that these drugs also protect kidney function in people with non-diabetic CKD, and we can add it to the toolbox for those patients as well.